I know the groups were numbered, and I don't know if you knew what number you were. Like, for instance, we were in chat room 4, and I'm seeing Kelly going, not on your life. So I'm just going to call out the facilitators, and you have to take yourself off mute if you're the speaker. And if not, if you were in the room with that facilitator and you are the person reporting out, then just turn your microphone on and we'll just start. So Dave, you're up in the corner. So we're going to start with your group. And I'm not even going to attempt to take notes because I want to listen. So we're going
All
to
right.
record you. And Taylor, I don't know where you are, but be sure you're recording. Okay,
Yeah.
David, you're up.
Well, Lexi is one of the nursing students at Tennessee State University. She is volunteered to present this, so I'm going to let her do that. I see your microphone's off.
Yes. So one of the things that we talked about was teach back is a huge important part in making sure that our patients are understanding what we are teaching them and what they need to know about taking care of themselves with taking medication, preparing wound dressings or cleaning or anything like that. So we do provide opportunities for them to ask questions in areas that they did not understand were very, very essential in their care. One of the things that we said that was important to make sure that health literacy is spread across our community is using social media and working with our churches. I know me and Shauna are both involved in church, and which Shauna is in my group. I'm sorry, she's in my cohort, and we are at Tennessee State University, like Dave said. And we work within these churches to provide different supplies to homeless. We provide tents or different hygiene materials that they can brush their teeth or take a bath in whichever sense that they are able to. Shauna did say that when she goes to church, she and works with her community with the homeless, that she tries to sit and just listen to what they have to say, their stories, and that gives insight to what we could do better and how to care better for people. And one area we did say that needed more attention was for the dental. We said that dental health really affects your entire body. If you don't have good oral hygiene or care, it can affect entire systems. So we think that proper transportation or bringing more awareness to free dental care or anything like that, or materials to provide hygiene is very necessary in these
Okay,
communities.
Leslie, I'm going to cut you off only because we've got a bunch of other groups to report. So let me just say to the groups, try to use, and it's not Leslie's fault because I didn't say that to her, but let's just use a minute or two to report out, or we'll be having lunch together.
Yes, I was done. I was done anyways. That was the
Okay,
end.
good. Okay. So Elizabeth, again, you're turn yourself off mute if you're the reporter, and just a minute or two on your highlights.
Sure. So our group had a great mix of clinical providers and community partners. And we talked a lot about how in the clinical setting, using, that same idea of listening, gauging how patients respond to assess literacy, just meeting patients where they are, wondering if measuring in the future, if we see improved health literacy, are we also going to see improved population health and management and care? One of our members talked about at her clinic, the EHR and the Cranes test and how it sends out handouts based on what patients say, but there's limitations there with reading level and having time to be able to explain that. And so we just rely on those handouts, that's not going to necessarily communicate things. Also, that assessments can be intimidating, that people may hesitate to respond because they don't want to be judged or feel shame around a topic. And then another barrier being waiting on approved government verbiage, like a clinic is waiting right now for COVID. So just knowing a lot of barriers that exist as well. And then looking at the opportunity for a community intervention that could be outside the clinical setting, that could to communities, especially looking at zip code health data, and picking up people who may not have access to healthcare right now, but it could be an entry point. So I work for the public library, and we talked about having more opportunities at public libraries to be addressing health information, health topics, that could be an entry point for people into healthcare as well. And then talking about relevant topics like right now, COVID vaccine, distrust, misinformation, opportunities to really be addressing what's critical in this moment.
Okay, great. Thank you. Kelly, you're on mute. There you go. Thank you.
I'm off. So my name is Kelly Sharon. I'm with AmeriGroup, and the lovely Katina Beard from Matthew Walker is going to report out for us.
Good morning.
Morning.
Yeah, so we had a very good discussion. We did not get to all the questions, but we did, but we had to rush at the end because we were having such a great conversation. And so we talked about how our organizations are already accessing health literacy by providing training to our members, to our clients, that we are using tools to assess our patients, and that some of us are going to start working and focusing more on our at-risk populations and doing follow-up. We talked a lot about what a community-wide effort would look like, right? So addressing social determinants of health, creating a steering committee or growing the steering committee that is organized with community-based organizations and other organizations that could be involved in the overall effort, making resources available to members to further promote among patients. And so making sure that we get more information out, that it's not just kind of held up in the big knowledge pools. Looking at the utilization of smartphones to use the apps that were discussed in the panels, making sure that it is clear, that it's functional for all levels, that it's easy to use, recognizing that patients will need more access to Wi-Fi because of the digital divide, and how we incorporate the work of students. So we talked a lot about using students. And so for my background, for where I am, it would be great if our providers could spend an hour talking to the patient, but that's really not our reality. And so how do we incorporate others in the visit that can help assess health literacy and help assess other social determinants of health? And looking at the new way that we use case management, and looking at other regions and their large scale use of case management, solidifying the Community Health Workers Association group in Tennessee, identifying, tracking, evaluating, operationalizing the informal processes that are taking place, and institutionalizing that work. And then we spent a nice bit of time talking about how we need to coordinate the efforts in Nashville or across Tennessee, and that there are very siloed effects or efforts going on, but that there is not one non-biased, non-inclusive organization that could bring together many voices to really focus on a single or direct health issue that we can all push forward to move the needle, and that health literacy would be a part of that conversation, and how we get away from the politeness, the funding fears, the politics, and embrace the diversity so that we can have a collective impact. And so under number 3, what resources, we discussed having the backbone non-competitive organization to formulate the work, and the ongoing and increased training to raise awareness.
Awesome. Thank you. Sherry Gibbs, you're on mute. You're still on mute.
Sandra is going to report out for our group.
Great. Sandra.
Hi, Vernon.
Hey.
Just for clarification, are we doing all 3 questions or just the first one?
I would say you can do any of you want to focus on the first, that's fine, and then send me info. If it's repetitive, find something new to say. It'll get harder and harder as we go down the block. So
Sure. So in talking about how to assess health literacy, we talked a lot about the efforts of getting out into the community and forums like this, which connect people, which normally wouldn't be together. We talked a lot about also harnessing students' efforts. I direct the undergraduate program at Belmont. And these students are in the age of, Gen Z generation, they're digital natives. They know a whole lot better about how to connect with Instagram and all the social platforms and how people want to consume that information. And, if we can get away from stodgy handouts with a lot of print on them and do something a little more creative that will be received by our audience, I think that would be a great way that we could use students. They're also very civically minded in this generation and they want to give back. And so judging from the numbers of schools we have in Nashville, I would think that we could use that resource more effectively. And it also gives them the clinical experience, public health experience of what we need in our communities. We talked a lot about marketing materials and piloting them first. We talked about how we're naturally siloed, and sometimes healthcare professionals are siloed, and we use a different language, which automatically sort of separates us from the people we're trying to reach. And so developing, again, more relationships, linking literacy to outcomes, I believe, is something really important. And we talked about how a lot of things in healthcare don't get attention until you link it to an outcome that's reimbursable. If you take Joint Commission goals, prevention of hospital infections, things that we should have been doing all along, we didn't do really until it started being connected to reimbursement. And so thinking of ways we can connect health literacy to outcomes and reimbursement, and getting a financial perspective in the forum. I don't know if we have anybody here representing a financial perspective and reimbursement perspective, but that might be important in the future.
I think as we're going to do this again, so absolutely we can pull that in. And I know that AmeriGroup could be a great help there too.
Yeah.
Can just nod her head.
Yeah, I think we also focused on the importance of faith communities linking into our public health structure. We've seen some real gaps with COVID-19 and our public health structure across the United States. And whatever we do, that we also link into the public health infrastructure, faith communities, et cetera. So that my peers can jump in if I missed anything big.
Sandra, great. We'll move on to another group. Let me, good job. Mark Overlock, are you doing your report out?
Yeah, my group was so full of ideas, I just started taking notes. So I've self-appointed myself the reporter.
Okay.
So one of the great ideas was, and we heard about surveying the patients sort of post-visit. One of the ideas is once you get that information, sit down with your sort of provider group and do almost a peer review and really sort of drop the myth of your own invulnerability and figure out exactly how you sort of miss the link with the patients. Every patient's different, obviously. A lot of them have language barriers and so forth. So that was a great suggestion. Also, be super attentive and be quiet. So we talked about how the Quakers in their friends meetings, the rule is don't speak unless you can improve on the silence. And so that's a great thing to sort of work with your patients on. Never assume that they can understand. Another great phrase from Sue Fort White is manage our vibe, which also is the great example of the doctor with his or her hand on the doorknob. Understand what you're communicating back, even though you're not speaking. We also want to assume our patients often are frightened. And so take the time to sort of de-escalate things and help them understand. Another great suggestion is our customer service representatives, the people at the front desk, this was talked about in the panels, make sure they have empathy. And that's not always something we can teach. So you really want to tease that out in the hiring process, because nothing's worse than the people at the front door, if you will, of your organization just not connecting with people as they come in or call for appointments, and just sort of manage all that. Make sure they have a ministerial sensitivity. So choose your staff well, make sure they have high social intelligence, and that's it.
Okay, thank you, Mark and group. Dr. Bond, you're on mute if you're, there you are.
Yeah, we have a student from Tennessee State is going to do our report.
Great.
Hi, I'm part of the Tennessee State University group with Lexi, who spoke before. So a lot of the points have already been said, so I'll just bring up something that I thought about. So I think one way to improve the community health literacy is just to start education on the children sooner. We talked about the social media aspects of it and everything, but I think the important part is to just kind of teach the children what they need to know a lot sooner. From my experience working, I had a little experience working in middle schools, but we were very limited in what we were able to tell the children in terms of just like health education. And these kids they're big kids at that point in time, and they're adolescents. So it would have just been nice to teach them more information in just general health, in sex education, whatever they might have needed later. They might not understand it at that point in time, but they would still introduce them to the information earlier on. And I think just as understanding, the more you're able to teach somebody, because it's been about teaching, the more they're able to grasp it later on. And this new generation, even though they are more tech savvy, they're interesting. They are able to grasp information better through their phones. But when it comes to computers, I found that they still struggle a little bit, which is the interesting part. But they're able to navigate the websites very well. And I think part of that too is that we, as just providers, should be able to get information out there that is correct. If the kids are looking at Facebook, through Snapchat, Instagram, Google, that it should be the more correct information that they're able to see first. So even going back to this COVID thing, like the mask, I actually think that kids are more likely to wear masks than the older adults. They struggle with that less, but they're able to understand the concepts that we teach them. So if we get them to, before they are an adult and their ideas have settled, it's easier to teach them other concepts that might improve their health and health literacy.
Okay, great. Dr. O'Leary, your group, are you speaking or someone speaking for you?
I am speaking. So I think a lot of the information has been shared, but we talked about just having quality, trusted information, trusted media, and really being focused on assessing in your population what they're looking for and making sure that you have materials to answer their questions available, and certainly not just written materials, but in a variety of formats. I do want to make a plug for not getting rid of written materials. A lot of populations use these not only to structure the provider conversation, but to take home and look at again with older adults or younger adults. And if it's only digital, that makes it much harder for certain populations. And so, we talked a lot about this later with social media, but this idea that we have to create materials in multi-formats so that people can use them. And the same people may use the same material in different formats for different purposes. And so we need to be thoughtful about that. Really thinking critical about what they're asking for, what they want to know, and how to give it back to them in a way that they can access it and use it. And then reflecting back on the conversations that we're having to make sure that we're constantly in a sort of QI circle. We're improving our quality and really addressing the needs of the community. In terms of community-wide efforts, we talked about getting people from a variety of sectors, education, healthcare, public health, libraries, all of those folks together, and then creating events that incorporate all the people who need information. We have to meet people where they are and give them the information that they want or need. So those two pieces go together. We can't just expect them to always come to us because it's easier for us or we have a great site or whatever. People are more comfortable in their own space and they identify differently. We know that the need is everywhere. So we can think about central locations in people's communities that work. Of course, this has been mentioned many times, but the faith communities, the churches can meet this need. And there's a built-in diversity in a lot of religious organizations, just in terms of age and race and geography and educational status. So you can get a lot of those social determinant check boxes met just by partnering with the religious organizations strongly and authentically. People are there and they trust those sources implicitly. The community health worker model is really important to develop and forge those relationships. But we talked a lot about, the community health workers are already subject matter experts in their community and they reflect the voice of the community. But we need to be careful in helping them become subject matter experts in health, that we don't sort of strip them of the elements that make them so powerful in the communities. So how do we train them and not take away what is already so important and so visible? And a lot of the models and the curriculum about community health worker, I think, lose track of the power of this model in trying to sort of overtrain them to become something different than they are. So we have to keep in mind who has the real expertise and power and let those people be themselves, because the authenticity is what shines through. And then in terms of resources, we talked a lot about collaborative efforts with all the key stakeholders, thinking about the roles, who provides the information, who disseminates, and finding partners who share the goal. If you don't have the same or similar outcomes in mind, they may not be the right partners for this initiative. We have to sort of go together. And then we have to use all of our resources. And this is where we really got into the social media. And we had also a student in our group who really talked about how do we use all of the materials and how do we create content that's tailored to the various platforms so that people can use things in many, many ways. And we use the example again of churches who've had to reimagine church at the core during COVID, but they've really practiced this and have had a live experiment. And so they can think about collaboration, who are the subject matter experts, how do we do this together and communicate central ideas together. And don't forget the government sources to help us think about policy and resources.
Okay, thank you.
Sure.
Amy, it's tough being the last two, so I'm gonna let you go ahead of me. So you're on mute. There you go.
Hello, everyone. So I'm Jamie Lee. I'm with the Nashville Healthcare Council, and we're proud to partner with everyone on this event. The conversation that we had a Lauren Boltz who's with Cigna, so we had a payer, and we also had a tech startup, someone with a history, Vicki Harris, who has a history of working with the aging population. So we had some really unique perspectives. For number one, about assessing health literacy, Cigna is doing some really great work around creating a social determinant of health index in some of the communities they serve. And they're doing this in a lot of different ways, but proactive outreach to patients that they already work with, but also implementing local outreach centers at like YMCAs and providing technology to meet people where they are. But I thought that was an interesting way to go about gaining or creating a social determinant of health index score. So that I thought was an interesting idea. And then also she said basically everything they put out just across the board general, if they not able to meet a specific need, is around the third grade reading level. So just kind of as a baseline. And then Vicki talked about a pilot that they're doing with Vanderbilt and the urban housing organization, that they're creating this baseline assessment for a pilot group of individuals. Health starts with the home. So a lot of interesting organizational partnerships is really important to kind of get things going. So, and doing an assessment of health literacy for communities we touch. Then around the community-wide to improve what health literacy might look like, again, really community collaboration is critical, leveraging the assets that are already available, really important to transition the key organizations within that community to a digital world. So many of them are still operating with paper. It makes it difficult to do work efficiently. So really transitioning those, strengthening the infrastructure, which I thought was really important to get things going. Also Vicki talked about a community up model. So you have to really build the communities up in order to connect to the payers and the providers and to complete the picture. So that was really an important point, I thought. Then Lauren talked a little bit, which I thought was really critical, is that as you collaborate in the community, it's important to check your organization title at the door, that no one necessarily needs to own the success, but the community should own the success of working together. And interoperability, really, really important. work that it still has a ways to go. But for those of you who don't know, and many of you may already, that there is an organization based here in Nashville called the Center for Medical Interoperability. They're doing some great work in this space. So those were our big ones. Oh, also acknowledging the mistrust perceptions that a lot of people mistrust payers or for-profit healthcare systems or just providers in general. So we need to be sure that we're addressing that and breaking down those barriers.
Jamie, thank you. So before I go last, am I skipping anybody, any group? I think I got them all. Okay, so our group, great conversation, tons of notes. I want to give an anecdote, and Molly was talking about this, as was Dr. Reyes, is that while everybody presumes that there is electronic literacy, in other words, access to the internet, what we're finding is that there's a significant group of folks, while they can access the internet, their flexibility once they get in there to assess that they've got a quality website, that they understand what they're reading, is limited. And so that is a challenge that as a group we need to look at. So I'm going to skip to the resources. And one more thing was, we want to make sure that when we're treating patients, that it's mind and body. Tom was from the mental health community with the stigmas of mental health and their own challenges, that we need that layer with us as we address health literacy. So these are our list of resources that we think are needed, that we think there needs to be, and I'm going to use it, either tips or instructions for plain language so that existing organizations can run against their existing materials and see if they're checking those boxes. That we believe there needs to be training on cultural humility and professional humility, so that there is that cultural sensitivity, linguistic sensitivity that's necessary to be successful. That we need to work not just on the skills of our patients, but their confidence in their skills. And that is another layer. Nobody else has said it, and we're going to say it. Money, yes, we need funding. So there'll need to be collaborative approaches on funding for this. What we would like to see ultimately is that there is a central place, and Elizabeth, hold your hat and you're not surprised, is a central place in collaboration with the public library and other sources like Dave Worland at the state of Tennessee, where we can go and that we create collaboratively. Katina, the thing that you were saying is that there is a collaborative community approach to this, and that there's a central place wherever that is housed, that we have an education campaign that provides the memes or the language or the tips or the infographics or whatever it is that we need, that we can all go to a place. And so if, in my case at the foundation, if I want to do, you know, a 6-month campaign on health literacy, there's a meme I can go pull. There's an infographic I can go pull that are pre-existing, that the group has said, yes, this is great. So that if Amarian's congregations, the 70 plus that he's got, are pulling from the same place that I'm pulling, and it's pulling from the same place that Elizabeth is pulling, that we start to have a visual that somebody goes, I was at church and I saw it here. I was at the hospital, I saw it here. I was at Matthew Walker and I saw it here, or wherever people are going, and they go, maybe I need to pay attention to this, because we all know COVID-19 has destroyed the trust in practically anything that has to do with healthcare right now. So we've got to rebuild that. So that's what our group is saying were some of the things that we want to do. So that's a lot. So where we are now is a minute from the hour. Oh God.
Hey, Vernon.
Yes.
Vernon, this has been fantastic. Congratulations. Great. I have to just say, amen to cultural humility.
Thank you, Sue. And for those who don't know, that's Sue Fort White, who is executive director of Our Kids, which is an amazing program that deals with kids that are suffering from abuse in the home. And they do amazing, not just Nashville work, but national work. Go to their site, Our Kids. It's Our Kids Center. Is that right, Sue?
ourkidscenter.com.
Thank
And
you.
it's,
Okay.
we're about child sexual abuse. Thank you, Vernon.
They're amazing. So again, for either recorders or facilitators, vernon.rose@nashvilleha.org, and you would have gotten an email from me anyway. But send me your notes. We're going to create a survey. Everyone that participated in the call will have a chance to go back in. Knowing me, it'll be tomorrow because I need a breather. No offense. I've been living health literacy for months. I need to think about anything else but that. I'm gonna go get a hug from my grandson who's 4. I don't know what I'm gonna do.
Get you a break, Vernon. Get you a break.
And then we'll right back at it. I don't know if Scott's still on the call, but Scott Massey, their group, that's the group you heard of from earlier that are addressing that collaborative effort in Hampton Roads. They're willing to step up and help host another forum soon so we can get back together, look at our results, and figure out where we go from here. And I think it was Katina that said it. This is not ever meant to be an exclusive group, ever in any point. It's if you know the next person that should be included, then invite them. This is not exclusivity. This is anybody. So if you know somebody that's in this space or missed it today, you'll get the link, share it with them. You know, if your professor, for the students that are on the call, if your professor missed it, then give them the link. So, because we're only going to succeed by the more and more people that join the conversation. So to that point, so if there's somebody that wants to weigh in on the survey, be my guest. You know, it's the more voices, the better off we are. So with that, and Amari, I know you've got 15,000 voices. If they want to weigh in, come on, have them all weigh in. Because that's the only way we're going to get there is if everybody is saying, this is important to us and we want to fix it. So I just want to say thank you. If anybody wants to take it themselves off mute and do a parting shot comment, be my guest. I'm going on mute. And thank y'all. Happy weekend.
I was going to say, I was about to type it, but I just want to say, great job, Vernon, pulling together our first health literacy forum. Being there with you from the beginning of listening it out and drawing it out, and this is what it's going to do, and this is where it's going to be. And now to see it come together in a virtual setting and all of the wonderful people that have participated, great job. Get you some good rest, and we'll continue the good work and make it even bigger for next year and even at a midway point through the year.
And excuse me, I forgot to thank all the speakers. So Katina and Tanae and the facilitators and everyone, excuse me, where are my manners? Thank you to everyone, Darcel, Lisa, everybody, thank you.
I just want to say congratulations to you. This is a really so well attended and engaged beginning discussion. And it's clear that there have been so many other discussions around this in every one of these organizations. So you're really well positioned for whatever comes next. And that's such a huge accomplishment. So congratulations to you and your organizations and the communities. And thank you for including me too.